Good evening, everyone. Now, quickly moving on to the next topic, acute respiratory distress syndrome. I would request chairpersons to please come to the stage. Dr. Manoj Mathur, sir. He's Professor Medicine, MLN Medical College, Prayagraj. Dr. Rajiv Gautam, HOD Anesthesia, MLN Medical College. Dr. Manish Kesri, Anesthetist, Acura Critical Care Hospital. I would now request our distinguished speaker, Dr. Bikram Gupta, sir, to please grace the dais, and would request one of the chairpersons to please introduce our speaker.
Privilege to introduce Dr. Bikram Kumar Gupta. He is Professor, Division of Critical Care Medicine, Department of Anesthesia, Institute of Medical Sciences, BHU, Varanasi. He has published several publications in peer-reviewed articles, book chapters he authored. He has been editor-in-chief of various books and editorials. He has various research supervisions, and he has guided 20 postgraduates, and he has ongoing 10 research projects under him. I request Dr. Bikram Gupta to start his talk.
Thank you, sir, for your kind introduction. Those for giving this opportunity and to discuss the very important topic, how to ventilate an ARDS patients. So we all know that the ARDS has very high mortality, and if we take the severe ARDS cases, in those cases the mortality is going up to the 25 to 40%. So this is very important topic, and as an intensivist we are encountering this type of the ARDS patient very often in our ICU, and sometimes it will be very difficult how to manage such patients when the patient is going into the severe ARDS and patient has the refractory hypoxemia. So I will not go in detail about the pathophysiology or so on. So just to start with a case discussion, see the 46-year-old woman presented to the emergency department with the fever, cough and shortness of breath, and that is worsening over the past 4 days. And there is no such significant past medical history prior to this current respiratory illness. And on examination, we found the tachypnea, decreased breath sound and sign of increased respiratory effort. Patient is conscious but restlessness. This is sign of the hypoxia. Vital sign, pulse rate is 122, BP is 128/60, SpO2 is only 70% on 6 liters of oxygen, and respiratory rate is 36 per minute, the tachypneic. On auscultatory finding, there are bilateral crepitations are present. We did the EBG in the emergency. The PO2 is showing 62 at the 6 liters of oxygen, pH is 7.43, PCO2 is 21 because of the tachypnea, and the bicarbonate is 18 because of the compensation of the respiratory alkalosis. So the EBG diagnosis, the primary respiratory alkalosis with compensatory metabolic acidosis and the moderate hypoxemia. We did the additional test, ECG sinus tachycardia, 2D echo showing the 60% of all chambers within the normal limit, and the lung ultrasound showing this is the B lines. This is the B lines, the vertical lines originated from the pleural membrane, and you can see the confluent B lines. It means showing the alveolar edema, not the interstitial edema. And this pleural line is a brachis, and there is a subpleural consolidation present. So these are the findings suggestive of the ARDS, not the suggestive of the pulmonary edema. And the X-ray is showing the bilateral diffuse haziness. This is also suggestive for the ARDS. So on the basis of this clinical history, on the basis of test, on the basis of ruling out the pulmonary edema, bedside 2D echo, lung ultrasound, and as well as the chest X-ray finding, the most probable diagnosis we can make is the acute respiratory distress syndrome. These are the differential diagnosis of ARDS, pulmonary edema, non-cardiogenic edema, as well as other causes like diffuse alveolar hemorrhage, eosinophilic pneumonia, lupus pneumonitis, or so on. So coming to the ARDS, the first clinical definition of ARDS was published in 1967 on the 12th August of 1967, and because of that date we are celebrating the 12th August as a ARDS World ARDS Day, and which was started by the Dr. Pradeep Bhattacharya sir, ICCM, as a ICCM president in the last year. And there are 12 case series published in the Lancet at that time. And then there are a lot of definition, and we are strict in the 2012 ARDS definition given by the Rennery et al., that is known as a Berlin definition. And now, just 2 years before that, there is some modification in this Berlin definition by the Michael et al., and that is known as the global definition of ARDS, just published 2 years before in 2023. So, as per the Berlin definition, they have also, in this new global definition also, as per the Berlin definition and the new global definition, both these definitions, the ARDS is divided into the mild, moderate and severe cases on the basis of severity. And time of installation, if it is all the symptoms or new worsening symptoms occurs within the 7 days, and this patient has the symptoms within the 4 days, with the non-risk factors. Pulmonary edema, initially in the AACC definition, they are saying on the basis of capillary pulmonary wedge pressure, but after the Berlin definition and this new global definition, that pulmonary edema is not on the basis of PCWP, it is on the basis of any sign of intravascular volume overload or any sign of cardiogenic edema. You can rule out on the basis of 2D echo or focus at the bedside. Radiological features, yes, there is bilateral infiltrate on the chest X-ray or CT scan, and that is not explained by the nodules, pleural effusion and the atelectasis. In the Berlin definition, they have not included the lung ultrasound because at that time there is no such popularity of the lung ultrasound. Even in the Harrison edition, it has mentioned that lung ultrasound is not very useful to diagnose the lung cases. But after 2012, in the last decades, there is a lot of use the ultrasound at the bedside by the intensivist or anesthetist, and they are seeing the B lines. They are ruling out which type of the pleural effusion. It is a transitive pleural effusion or exudative pleural effusion, and many so pathology on the basis of lung ultrasound. And seeing that popularity in the new global definition of the ARDS, they have included the lung ultrasound, but it should be by the trained professionals. Hypoxemia, PF ratio, on the basis of PF ratio, you can divide the mild, moderate and severe ARDS, but here they have also included the HFNO, and this concept of HFNO comes after the publication of Amato et al. In the NEGM in 2015, and after this COVID period or during this COVID period, a lot of use of HFNO, and this HFNO is also included for the defining the mild ARDS. And in the resource limited setting where the ABG is not available, you are not able to see the PO2. In those conditions, you can see the SF ratio, or on the basis of SF ratio, you again define the ARDS. So, in case of resource limited setting, you have to see the time, you have to rule out the pulmonary edema, you have to go for the relative features, you see the SF ratio, not the PF ratio. So, there are three, on the basis of this new classification, there are three categories of ARDS. One is the intubated ARDS, second is the non-intubated ARDS when the patient on the HFNO, and third one is the ARDS in the resource limited setting where you are using the SF ratio, not the PF ratio. So, there are three categories of the ARDS as per the global definition. Coming to the case, the patient on the basis of this clinical criteria, either you are using the Berlin criteria or ARDS updated ARDS global definition criteria, the patient is fitting into the severe moderate ARDS case. So, the patient given the first in the emergency, patient has started with the NIV support with the IPAP of 14 or EPAP of 10, and that oxygen started with the 12 liter. Vital signs on NIV, BP is 110/70, pulse rate is 132 per minute, SpO2 is 92% and respiratory rate is 35 per minute. After 2 hours on the NIV, patient's vitals get deteriorated. Now we did the EBG is showing the pH of 7.52, PCO2 of 26, PO2 is only 45 and bicarb is 20. So, when to give the NIV? Because patient after the NIV, patient get deteriorated here. So, this is a very important question if such type of presented to you in the emergency department or in the ICU. So, when we will give the NIV? So, as per the research, as per the studies which has been published, we only go for the NIV application in case of the mild ARDS where the PF ratio is in between 200 to 300. And if you want to give the NIV, then you have to assess the patient and give the just trial for 1 hour or 2 hours. So, only it is reserved for the mild ARDS cases, not in case of the moderate to severe ARDS case, and it should be reserved for the hemodynamically stable patients, patient who can closely monitor in the ICU, not put the patient, not just, even if you are using the NIV in the mild ARDS patient, so monitor the patient in the SDU or ICU, not in the putting the patient in the ward only. So if you are going for the NIV, it will delay the intubation. In case of the moderate to severe ARDS, there will be very poor tidal volume control. You're not able to, because there are a lot of because of the hypoxemia, patient become very restlessness, and it is very difficult to measure or assess the tidal volume in such patients. So very poor tidal volume control. This is new concept. Patient has a lot of self-inflicted lung injury because of the too much tachypneic. Patient has a lot of lung injury because of the injury at the junction of the alveoli, and patient, because of that, patient has too much PCL. Alveolar instability can occur with the NIV. So if you are giving the NIV trial, just monitor the patient, see the early failure risks and the late failure possibilities. If the patient is improving initially, then always look for the late failure possibility. Watch for the late deterioration even if the patient shows initial improvement of the NIV. So if the patient initially improving, don't forget to monitor. Always try to monitor the patient and see whether the patient is improving later on or not. So in these patients, patient become more restless, patient become more breathlessness, vital signs get deteriorated, pH get worsening, PCO2 is 26, PO2 is only 45, and pH is 7.52. So if we have, because in this patient, even in the moderate hypoxemia, patient has given the NIV trial. It is not as per the studies, as per the published article, but if you are given the NIV trial in such patients, patient is not improved here, so we have to go for the intubation part and invasive mechanical ventilation. So discussion on the next step is the mechanical ventilation. What should be the ventilation goal? What should be the initial ventilator setting? And the most important is how to minimize the ventilator-induced lung injury. So this is very important. If you are keeping a patient on the ventilator, you better to take the benefit. It is the second important one. Before that, you have to think about that, how to minimize the ventilator-induced lung injury. This is the most important one. So the most important concept, whenever you are putting a patient on the ventilator in ARDS cases, always try to minimize the lung injury, ventilator-induced lung injury, and after that, you can take the benefit of the ventilators. So why this is important? Because in the ARDS lung, there are three important components in the ARDS lung. The first one is the diseased lung, that is not recruitable. That lung is totally just like a tissue structure. It's not able to recruit that lung even how much amount of PEEP you are applying on that area. The second part is the diseased lung, but that lung is recruitable. That lung will be open with the PEEP application. And the third one is the normal lung, and that is the unaffected lung unit. And on the basis of that, the baby lung concept has been arises, because we are just want to ventilate only that part of a lung. We want to save that part of the lung. Don't give the too much of the tidal volume and to injure that healthy part of the lung, just applying the too much amount of the tidal volume. So whenever you are ventilating the ARDS patient, you need to think about that this patient has a lung just like the baby, so we have to deliver the tidal volume. In that amount of tidal volume, we have to give that lung in which it will not injure that healthy lungs. So always try to prevent your goal of ventilation to reduce the ventilator-induced lung injury. So always try to prevent the barotrauma, volutrauma, biotrauma, or atelectotrauma. And these are the major important part of the major important domain of the ARDS treatment. The first important is the low tidal volume ventilation. The last ARMA trial published in the 2000, the landmark trial, and even after the 25 years, the concept of the ARMA trial to ventilate the ARDS lung with the low tidal volume ventilation has not been changed. So even after the 25 years, the most important concept for the ARDS ventilator strategy in the ARDS is the low tidal volume ventilation. So this concept is remain same even after the 25 years. We have to give the tidal volume of 4 to 6 ml per kg. Then the second most important, which gives the survival benefit, is the prone position. So early prone position, if the patient is not improving with your ventilator strategy, PF ratio is less than 150, then they do the early proning, and for the long duration, for the 12 to 6 hours, and definitely it will give the survival benefit as per the trials. Other things, driving pressure, conservative fluid management. The new concept is the mechanical power reductions. Individualized PEEP titration, a lot of debate since 25 years, how much amount of PEEP we should apply. It is not still clear. Many of authors suggested that incremental PEEP, some as a decremental PEEP, or CT guided PEEP, or ultrasound guided PEEP. A lot of publications regarding the PEEP. Now the concept is the individualized PEEP titration. Whether you have to give the glucocorticoids or not, it is also the important discussion for the management of severe ARDS. VB ECMO, definitely when the patient fails to the prone position, we can go for the VB ECMO. Neuromuscular blockade, when to give the neuromuscular blockade, for how much duration, we will discuss about that. And there is role of, whether there is role of inhaled pulmonary vasodilators or no. So as per the adult ARDS, there is no role of the inhaled pulmonary vasodilators. Definitely it has the significant role in case of the neonatal ARDS. So the most important, the first things which I want to discuss here regarding the ARDS management is the low tidal volume ventilation. And you have to measure the predicted body weight first on the basis of this formula. Then on the basis of this formula, you can calculate the predicted body weight, and then according to that, you have to start with the 6 ml per kg of the predicted body weight. Your rider is the plateau pressure. So whenever you are delivering the tidal volume with the 6 ml or 4 ml or 5 ml or 7 ml or 8 ml, your rider will be the plateau pressure. So you have to measure the plateau pressure after setting the tidal volume of the 6 ml per kg. If the plateau pressure is less, what is the plateau pressure? Plateau pressure is it tells about that if you are keeping the plateau pressure of less than 30, you are minimizing the ventilator induced injury, you are minimizing the biotrauma, barotrauma or volutrauma. So if keeping the plateau pressure of less than 30, it means you are minimizing the ventilator induced lung injury. So start with the 6 ml per kg, measure the plateau pressure. If the plateau pressure is less than 30, then it is good. If the plateau pressure is more than 30, then decrease the tidal volume of 6 ml to 5 ml. Again remeasure the plateau pressure. Again it is more than 30, then again reduce the 5 to 4. So, and if it is less than 25, then you can increase the 6 to 7 or 7 to 8. So range is 4 ml per kg to the 8 ml per kg. It depends on the how much tidal volume patient has. So which ventilation mode? You can select the volume assist control mode or pressure assist control mode. Both modes are equally good. It is just important in the pressure assist control mode, you have to be at the bedside, because in the pressure assist control mode, the tidal volume is generating on the basis of pressure gradient, how much peak inspiratory pressure you have applied and how much positive expiratory pressure you have applied. So on the basis of PIP and PEEP, the tidal volume will be decided. If initially the patient lung is very bad, if you are intubating the such patient and keeping on the pressure assist control mode with the PIP of, just say example of PIP of 28 and P of 10, so on the basis of gradient, it is a gradient of 18, the tidal volume is delivering at that time is 400 ml. But after some time, because of your mechanical ventilation strategy, because of your treatment, the same pressure gradient patient will then generate the tidal volume of 500 or 550, and it will injure the lung. So the only things you have to keep in mind whenever you are selecting the mode, if you are keeping the patient on the pressure assist control mode, you have to be at the bedside and try to decrease the PIP on the basis of tidal volume, or keep the tidal volume at the range of the 6 ml per kg. So measure the plateau pressure and tidal volume, already spoke about that. I ratio 1:1 or 1:3 on the basis of PO2 and PCO2, you can decide how should be the range, how should be the ratio, how much ratio, 1:1 or 1:2 or 1:3. You have to keep the PO2 of 55 to 80. Don't try to keep the PO2 of more than 100. SPO2 is 88 to 94%, or better to keep the SPO2 of 88 to 90%. Don't keep the SPO2 of 100% in case of the ARDS patient, it further injure the lung. Acidosis management, if the patient has less than 7.15 pH, increase the respiratory rate. Even that, if the pH is less than 7.15, you can give the soda bicarb. So both modes you can use. Now moving to our case, in this patient we have put the patient on the mechanical ventilation. It started with the volume assist control mode with the tidal volume of 350 ml per kg, with the 100% of FI2, PEEP of 14, respiratory rate of 24 per minute, and plateau pressure at that time is less than 30 on the 6 ml per kg of the tidal volume. Patient's vitals, pulse rate is 130, SpO2 is 92% on the 100% of FI2. Blood pressure 127, respiratory rate 24 per minute, and we have started the sedation as well as the neuromuscular blocking agent with the cisatracurium. Recruitment maneuver, nowadays there is no such role of the recruitment maneuver, but in certain cases where the severe hypoxemia persists, you can use the recruitment maneuver, but as per the recent evidences, we can't go for the recruitment maneuver. These are the methods of the recruitment maneuver. If you want to use if you want to do the recruitment of the lung in case of the refractory hypoxemia, then better to go for the staircase recruitment technique. Your approach should be either the incremental PEEP approach or decremental PEEP approach. These are the evidences in which there is no such benefit of the recruitment maneuver in case of the ARDS patient. The new concept is the driving pressure. After the plateau pressure, the next pressure is the driving pressure. What is the driving pressure? Driving pressure means it is the P plateau pressure minus PEEP. So it is better to optimize the PEEP. If you are using the driving pressure, will be helpful to optimize the PEEP. See, if you are keeping a plateau pressure, if you are keeping the PEEP of the 10, and after keeping the PEEP of the 10, you measure the plateau pressure. If the plateau pressure is at the PEEP of the 10 is the plateau pressure is 30. So 20 minus 10 is the 20. You just want to keep the driving pressure of less than 15. Gradually we will increase the driving pressure and see the plateau pressure as well, and then subtract the you can calculate the driving pressure by subtracting the PEEP from the plateau pressure. At that PEEP, when the driving pressure is less than 15, that is the good PEEP for that patient. So for optimization of the PEEP, you have to measure the driving pressure, and in those PEEP where the driving pressure is less than 15, you can keep the patient on that PEEP. Now after that, this ventilator settings, again maybe see the vitals of the patient. Now the pulse rate is 140, BP is 130/80, SpO2 is now the 84% only on the 80% of FI2, and respiratory rate is 24 per minute. ABG showing the PF ratio of 105 with the PCO2 of 80. So despite low tidal volume ventilation, we have given 6 ml per kg, optimal PEEP titration on the basis of driving pressure. We have started the appropriate sedation and neuromuscular blockade. We have given the recruitment maneuver because of the refractory hypoxemia, and we are keeping the driving pressure of less than 15 mm of Sg. Even that patient has the SpO2 of only 84% with the 80% of FI2, and PF ratio is 105. So the patient continue to have the significant hypoxemia, indicating the need for the additional rescue strategy. What all rescue strategy we will do here? So this is very important. So early proning is very important. If the patient has the PF of less than 150, better to go for the early proning, and it will give definitely the good result or survival benefit as per the PROSEVA trial as well. So patient was prone for the 16 hours with the proper positioning protocol. So improvement in the ABG in the terms of the PF index and PCO2, but after 16 hours, when we did the supine position, again patient gets dissociated after the few hours. So again reproning was done for the another 16 hours. Now the patient on the volume assist control mode with the tidal volume of 6 ml per kg, respiratory rate is 30, P plateau is 28, PEEP of 14, and driving pressure is 14, and PF is showing the 180, PCO2 is 74 now. So PF index is improved from 105 to 180. Then PCO2 here is the 74. So what will you do? How will you minimize the ventilator-induced lung injury now? So here the concept is the mechanical concept of the mechanical power is come. This concept just 3 and 4 years before, and as per this mechanical power is the energy delivered to the respiratory system per unit time during the mechanical ventilation. It represents the total mechanical load applied to the lungs, can be calculated using by the following equation. So see here, mechanical power depends on the tidal volume, respiratory rate, PEEP, plateau pressure. All these things affect the mechanical power. So not only the tidal volume and the pressure will decide the lung injury. So flow, pressure, tidal volume, plateau pressure, PP, everything will affect the ventilator-induced lung injury. And as per the study, better to keep this mechanical power at the 17 to 20 joule per minute. If you are keeping the mechanical power of less than 17 joule, it will decrease the mortality and morbidity as well. So how will you reduce? Reduce this mechanical power? Keep the low tidal volume. Do the low tidal volume ventilation, optimize the respiratory rate, minimize the driving pressure, consider the pressure control ventilation to limit the peak, and unnecessary high inspiratory flow rate. So always keep the low flow. Proning, already discussed about that. Even after proning with the mechanical power of less than 70 joule per kg, patient has the refractory hypoxemia and PCO2 of more than 80 mmHg with the pH of less than 7.21. So now as the patient has already went for 2 times of the proning position, even that the patient has the refractory hypoxemia and the patient has the permissive hypercapnia both, and that is affecting the pH as well, and pH is less than 7.21. Now we can go for the ECMO, and gradually we wean this patient, we plant the ECMO, and then patient was weaned from the ECMO gradually over the days. So these are the indication of ECMO. If the patient has a severe refractory hypoxemia despite the optimal conventional therapy, PF ratio is less than 80 with the FI2 of more than 80% for 6 hours. Patient has a severe respiratory atherosclerosis with the pH of less than 7.25 and excessive plateau pressure more than 35 despite the reduced tidal volume. At that situations, we have to go for the early ECMO. So early ECMO and early proning will give the definite results, or it will reduce the morbidity and mortality in case of the ARDS patient. So ECMO should be always considered in the specialized center for the carefully selected patient with severe ARDS that is unresponsive to the conventional therapy. So this patient was discharged, tracheostomy was performed during the ICU stay and discharged after 60 days. Patient discharged after approximately 60 days of the hospital admission, and decongestration was done later on during the follow-up. Is there any role of nitric oxide? Despite the physiological benefit, meta-analysis have not demonstrated a consistent mortality benefit with the inhaled nitric oxide in the ARDS. Any role of steroid? Yes, 3 evidences: DEXA ARDS studies, recovery trial, and the COVID steroid 2 trial, saying that if you are using the steroid, use it early for the at least 10 to 14 days and gradually wean from the steroid. It has definite benefit. If you are using in the late condition, when the already fibrosis of the lung settle down, in those conditions there is no such role of the steroid. So patient selection is very important. Individualized therapy based on the patient characteristics and comorbidities. Consider the risk benefit profile in patient with a diabetes, immunosuppression, or any active infections. Regarding the neuromuscular blocking agents, yes, you can use the neuromuscular blocking agent, but for less than 48 hours in case of the severe refractory hypoxemia and in the prone position. Fluid management, we have to go for the conservative fluid management, not go for the liberal fluid management. So these are the important summary in case of the ARDS ventilator management. The most important is the low tidal volume ventilation. Keep the plateau pressure of less than 30. Keep the driving pressure of less than 15. Early proning or early ECMO if indications. Thank you so much. So this is the very, the Gatinino is known as a father of ARDS. He said that mechanical ventilation is necessary evil in the ARDS. If correctly performed, mechanical ventilation buys time to allow other therapy to take effect. If performed incorrectly, it may kill the patients. So machine is not important one. The machine, the main behind the machine, the brain behind the machine is most important to deal such patients. So thank you so much. If you have any questions, we can discuss here.
Now the session is open for any question and answers. Thank you, Dr. Bikram Gupta, for giving such an insightful management and current guidelines on a very, very important topic on ARDS. Thank you very much.
I would now request our President AMA, Dr. J.V. Rai sir, President-elect Dr. Ashok Mishra sir, and Honorary Secretary AMA, Dr. Ashutosh Gupta, for felicitation of our distinguished speaker and chairpersons.